So thank you, João, for your presentation. Thank you for the invitation to you, to the Foundation. It's a pleasure to be here today. And I was adequately introduced already, so let's jump to the slides. So this is the banner of what this meeting is all about: psychotherapy, pharmacology, and neurobiology. No one told me this, but I'm guessing I'm invited here more to talk about the pharmacology and neurobiology more than the psychotherapy. I was brave enough to talk a little bit about psychotherapy at the end. Let's see if I'm sufficiently provocative to induce some discussion. So the summary of my talk is that I'm going to start talking about psychotropic drugs. I'm going to concentrate mainly on antidepressants, and the reason for that is basically that I'm lazy. This is what I know more about. This is what I do research about. So I'm going to talk about what I know best, which is depression and antidepressants. And I'm going to touch on psychosis just very, very briefly. Then I'm going to talk about electroconvulsive therapy. I'm sure I'm going to touch a nerve somewhere talking about electroconvulsive therapy, but I'll just take that risk. I'm going to talk about my very specific area of interest and of research, which is non-invasive brain stimulation, something I have some publications on, I'm working currently on, and that I'm hoping to further develop. Then talk about deep brain stimulation, definitely also touching several nerves, about psychosurgery, about the relevance of psychosurgery today. And finally, the more provocative element, talking about randomized controlled trials, about psychotherapy, and about placebo effects. So, antidepressants and psychotropics, how did we come about the drugs that we use currently to treat depression? Well, essentially we stumbled upon them. It was pure serendipity. In the 50s, iproniazid, that was de facto our first antidepressant, monoamine oxidase inhibitor, was discovered in hospitals treating tuberculosis. Iproniazid is a tuberculostatic agent, and what the physicians there figured out was that the patients being treated with iproniazid were happier, were more interactive, were eating better, were sleeping better, and some were actually, to some degree, losing their mind. They were very agitated, manic, hypersexual. And so the physicians in these hospitals were smart enough to talk to people in the asylums, start testing these drugs, and it was very clear that they were effective in the treatment of those that were most depressed. Imipramine came up more or less at the same time. A few years prior, scientists had stumbled upon the first antipsychotic, also entirely from serendipity, and were developing drugs that were similar to that first antipsychotic, that is chlorpromazine. Kuhn, who was a psychiatrist in Switzerland, was given an experimental drug that we currently call imipramine to test in patients with psychosis. He wasn't very excited about the antipsychotic efficacy of imipramine, but he realized that in patients that were psychotic and depressed, they did get much better from both their depression and their psychosis. And this brought about all the development on a different class of antidepressants, which are the tricyclics, which we still use today. So these were essentially the main drug classes that were used for several years. There are psychiatrists sitting in the audience that I'm sure had these tools only for a part of their career. But in the late 1980s, essentially because of the severe side effects and the severe restrictions that some of these drugs had in terms of their clinical use, the industry and academia set upon developing and validating a new group of substances that was more targeted to depression and had less side effects. So this was a time when the first selective serotonin reuptake inhibitor came on. The first one was not Prozac or fluoxetine, it was actually Zimaldine, wasn't very successful in terms of getting into clinical practice, also because of side effects. But fluoxetine, so the brand name everyone knows about is Prozac, was hugely successful, revolutionized the practice of mental health care and of psychiatry, and is still today probably one of the best cases of success, both clinically and from a market perspective in terms of the pharma industry. So this is, the light here doesn't make it very easy, but I'll try to be as explicit as possible. All of these drugs, all of the main groups of antidepressants that we work on as psychiatrists, act essentially on the monoaminergic circuits, on serotonin and on noradrenaline. For example, monoamine oxidase inhibitors, they inhibit the breakdown of these substances, both inside the neuron and in the synapse. Tricyclics essentially inhibit the reuptake of both serotonin and noradrenaline into presynaptic neurons. And selective serotonin reuptake inhibitors, as their name makes very clear, selectively inhibits serotonin intake, but has very little or no effect on noradrenaline uptake. And with now more than 50 years of development of these drugs, with many, many different drugs that are in clinical practice, what we can say globally is that efficacy among these several drugs is more or less equivalent. So they all are similarly effective when used for treatment of depression. And there's a hint of evidence that venlafaxine, this is a specific serotonin and noradrenaline reuptake inhibitor, and tricyclics could be slightly more effective in the treatment of severe depression than selective serotonin reuptake inhibitors. So our main reasons as psychiatrists to choose between different antidepressant drugs are essentially side effects, toxicity, and cost. With all of these options, with all of these alternatives for treatment, we still have approximately 50% of individuals that we treat that have no response to treatment or incomplete response to treatment, and for whom we need to develop alternative options for therapy. These are the cases that are generally called treatment-resistant depression or refractory depression. The formal definition is that they have gone through 2 full cycles of 2 different antidepressants at full dose. And for these patients, what we typically do as a first, well, actually here as a third line in terms of their treatment, is to do some add-on treatment for their depression. Lithium, the first mood stabilizer that is used for bipolar disorder, is one of the options as an add-on for refractory depression. Atypical antipsychotics like quetiapine or aripiprazole are other alternatives as add-ons for refractory depression. And thyroid hormone is also, interestingly, an option for treatment of these patients. These 3 are reasonably typical. They're used in most psychiatric departments around the world. There are few other options that are also used, maybe more selectively and much more in research-based protocols. Stimulants are used, mainly in old age depression. Opioid agonists like buprenorphine are starting to be used also in old age depression. And some more interesting substances like ketamine, which is an anesthetic and also used as a street drug, is currently being tested for depression. And psilocybin, and I'm sure you heard about this yesterday in a presentation in the afternoon, has been one of the examples of the substances being tested in what is a very new branch of psychiatry, which is the branch of psychedelic psychiatry or psychedelic medicine. So, talking about refractory depression without talking about electroconvulsive therapy would definitely be a mistake. So electroconvulsive therapy consists on the induction of a generalized convulsion using electrical stimulation in an individual that, the way it's done today, is under general anesthesia. The history of electroconvulsive therapy actually predates the history of pharmacology. A Hungarian neuropathologist, Dr. Ladislas Meduna, was the first to propose a symmetric relationship between epilepsy and schizophrenia from his investigations of post-mortem brain slices in individuals with these pathologies. So what he described was that the cellular characteristics of neurons in epileptics and in schizophrenics were in opposite sides of a spectrum that in the middle had normal individuals. And his proposal was, well, why not try to induce epilepsy in individuals with schizophrenia in order to try to treat their disorder. Initially, still in the 1930s, substances were used to induce epilepsy, first camphor, then this very complicated substance, I hope I'll be able to pronounce correctly, pentyl-N-tetrazole, which we obviously don't use anymore. And these substances were used to induce seizures, but there was a huge incidence of side effects, of mortality. They stopped being used very rapidly. And it was in 1938, the late 1930s, that two Italian neuropsychiatrists started to develop protocols for the use of electricity to induce seizures in psychiatric patients. So Ugo Serletti and Lucio Bini very successfully tested this first in animals, which I think is very prudent, for the time not very usual. So they were able to demonstrate that by inducing seizures through application of electricity only to the head, the mortality rate was very, very low. And so very rapidly, this went into practice with humans and was used in patients in asylums. And it became very, very successful because there was a sizable group of individuals. And let me remind you, this was prior to the availability of any useful psychotropic that we're using currently. So at this time, there was no pharmacological option for these patients. So obviously, the alternative to have something like electroconvulsive therapy applied over a few sessions in less than 1 month and have the patient recover sufficiently to go back home and recover functionality was, at the time, very much revolutionary. And this picked up very rapidly and started to be used with enormous frequency across psychiatric hospitals all over the world. So the initial days of electroconvulsive therapy are obviously something that I believe no one is particularly proud of. This was done to some degree indiscriminately across all patients. It was done with no anesthesia, and it was very frequently done without adequate consent from patients. And cinema and literature also very quickly picked up on that and participated in the global vision, the global very negative vision of electroconvulsive therapy and of its use in psychiatry. And still today, there are very active groups that manifest against the funding and the use of electroconvulsive therapy, mostly in the United Kingdom. And this is an example of a real manifestation in London against ECT. And the history of ECT, given this bad reputation and given the emergence of drugs that were effective to treat schizophrenia and to treat depression, was that it very rapidly declined. So this is a paper describing the percentage of individuals that received electroconvulsive therapy amongst those admitted acutely in psychiatric hospitals in the United States. And what you can see is that in 1975, almost 6% of all patients admitted acutely were submitted to electroconvulsive therapy, while in 1986, just 11 years later, that number had dropped to under 3%. But however way we really look at this, the fact is that specifically in depression, electroconvulsive therapy is very much effective. So these are studies that, as you see, this is a meta-analysis. So a meta-analysis is essentially a way to condense the evidence across different studies. I'm going to show you data from several meta-analyses in this talk. So here we have 6 studies done over the 60s, 70s, and early 80s, comparing active electroconvulsive therapy to simulated electroconvulsive therapy. And simulated electroconvulsive therapy is essentially anesthetizing the patient goes to sleep, and then no one does anything, and the patient wakes back up again. So the patient will believe that he or she had electroconvulsive therapy, but really did not. So essentially, it's the way to do a placebo intervention in the context of ECT. What we see here is that it's very clear across these studies, and for obvious reasons, these are studies we don't do anymore. There is very consistent evidence that individuals treated with the electroconvulsive therapy that actually did receive the convulsion improve more than individuals receiving the simulated ECT. And in research that is much more common, and that you will still see some examples occurring in more modern times, when one compares the use of antidepressants to the use of electroconvulsive therapy in randomized controlled trials, electroconvulsive therapy consistently comes out as more effective than pharmacological alternatives. And also, very, very importantly, from a clinical perspective, patients with severe depression that are treated with electroconvulsive therapy improve faster than patients that are under the same conditions and treated with medication. As we can see here, while the group of individuals treated with ECT are improving significantly at the 3rd week of treatment, the individuals that are being treated with medication are improving much later on. And so efficacy and speed of response was essentially what made electroconvulsive therapy live on. And it was the subject of a rebirth, let's say. There's a resurgence of interest, and similarly as we have patients that manifest against the use of ECT, we now have patients that are advocates for access and advocates for the possibility of accessing ECT if it's necessary. And modern ECT is very different from what was done in the 40s, 50s, 60s, and even 70s. So now the patient is being treated under general anesthesia with neuromuscular blockade to avoid all of the side effects from a generalized muscular contraction. And there's physiological monitoring to reduce the risk of side effects, for example, of side effects in terms of heart rhythm after the generalized convulsion. Treatment parameters have also been optimized. So there have been changes in current type, in electrode montage, in dose titration, and this has not only improved efficacy, it has reduced side effects. And we are now much more strict about in whom we use electroconvulsive therapy. Our primary indications are for patients in whom we want to see a very fast response to treatment. So patients that are refusing food and fluids, patients that are catatonic, patients that are at a very high suicidal risk, where time is a very important element, where if we use a treatment that will take longer, the patient will also be at risk for a longer period of time. Secondary indications, where the treatment is actually less effective, but it's still the most effective of all available treatments, are the patients that have not responded to other alternatives, that have not responded to pharmacological drugs, that have not responded to psychotherapy. These are individuals that should also be considered for ECT and to whom ECT should be offered, because in these patients there's a significant proportion of them that will improve while not having improved with anything else prior. With much less evidence, there's also support for the use of ECT as a second or third line alternative in patients with schizophrenia that do not respond to any of our alternate hypotheses, do not respond to first line antipsychotics, do not respond to our last line antipsychotic, which is clozapine. In these patients, there is, I wouldn't say as solid of an evidence as for depression, but there is some evidence that the use of electroconvulsive therapy will allow a proportion of these individuals to recover both from symptoms and in terms of function. But it's not all good, obviously, right? There are risks, there are contraindications, and one very important side effect are cognitive side effects. So electroconvulsive therapy has an impact on memory. And while this impact seems to be temporary, so after enough time has passed from the electroconvulsive therapy, the impact on memory is actually of improvement rather than reduction. This is something that obviously worries patients and should worry the psychiatrists that are prescribing electroconvulsive therapy. And essentially that has brought upon the need to develop alternate possibilities to stimulate the brain focally in the absence of the need to do anesthesia, to do neuromuscular blockade, to induce important side effects such as memory loss. And that investment has been done for several decades now, and there are two main options for non-invasive focal brain stimulation that are in current clinical use or experimental use currently. One of them is transcranial direct current stimulation, essentially using much lower intensity of electrical stimulation placed on the scalp to induce subthreshold stimulation of the brain tissue. The other one, which is the area that I'm most interested in, is transcranial magnetic stimulation. So what we do in transcranial magnetic stimulation is that we have a metallic coil and we pass electric current at a very high speed on that magnetic coil, and that induces a high field, high intensity magnetic field that upon touching on any underlying tissues that can conduce electricity is going to induce electrical activity in those tissues in an absolutely non-invasive fashion. And so what you would see in someone receiving transcranial magnetic stimulation, for example, in the occipital cortex would be something like this. So the coil is placed over the head at our target position, the individual is awake, there's no need for anesthesia. The only thing we need to worry about is that this is noisy, we need to protect their ears, and typically this is done when we are trying to achieve some therapeutic effect. This is done over several days across a multitude of weeks. So the use of TMS is done in single pulses that can or not be repeated across time. So repetitive TMS is actually the approach that is used for treatment in neuropsychiatric disorders. And repetitive TMS is, as the name indicates, repeating the pulses of stimulation across time at very given intervals. So if we do slow repetitive TMS, which is the image on top, which is 1 hertz, so 1 stimulus per second, what we're going to see in the stimulated area, which is on your right-hand side, is a reduction of activity of that cortex. So slow RTMS slows down the cortex. If we do high-frequency stimulation, 10 or 20 hertz stimulation in the same area of the cortex, what we're going to see is an increase of activity. So it's excitatory, it's stimulatory. And this has been extensively replicated across multiple species and across multiple conditions. And high-frequency repetitive TMS is now an FDA-approved treatment for refractory depression in the United States. And it is very much of current use there and with increasing implementation in Europe and other places of the world. So this is data that I'm showing here for the approval that was used by the company, Neuronetics, to approve the first device for RTMS in depression. Well, we see the line on top, the gray line, it's the improvement of patients that were receiving sham RTMS. So where the coil was being placed on their head, the noise was being simulated, the stimulation of the skin was being simulated, but there was no actual stimulation being delivered to the brain. And the line in blue that goes lower down is the line of symptom improvement and of depressive symptom improvement in individuals that were receiving real RTMS, where the brain was actually being stimulated. And according to the difference between the two treatment groups, the FDA thought this was sufficiently a sufficiently large difference to approve the treatment, and that's why currently there are several hundreds of centers using it across the United States. RTMS has also been tested for other conditions, as usual in psychiatry. The most common disorders are the ones that will accumulate evidence first, but there is also some research going on for RTMS in the context of schizophrenia, both for positive and negative symptoms, either doing low-frequency stimulation to the left temporal cortex for positive symptoms, or high-frequency stimulation in the left dorsolateral prefrontal cortex for negative symptoms of psychosis. I myself have been involved in validation of new devices for treatment of RTMS in depression. This is a trial that was published just this year, comparing the currently approved device to a new device that is actually produced in Europe, the Maxtim, and showing that they have equivalent efficacy in the treatment of depression. Meta-analyses have been conducted looking at the several papers publishing sham versus active RTMS for depression, and the conclusion from these meta-analyses is that overall there is robust evidence of an antidepressant effect for RTMS. And I have been working with other colleagues at the Champalimaud to collect the evidence in a new meta-analysis, trying to understand what are the long-term effects. So how durable is the effect? Does it last just a couple of weeks? Does it last months? Our evidence suggests that the treatment is durable. At 3 months after the end of treatment, approximately 55% of the individuals that remit will still be under remission, and this is similar to what we find both for antidepressants and for electroconvulsive therapy. And importantly, we were also able to demonstrate that at 6 months and 12 months of treatment, when individuals receive maintenance RTMS sessions that are used in different centers differently, either weekly, monthly, bi-weekly, etc., that the probability of relapse is lower. We have also demonstrated that among individuals that relapse after an effective course of induction RTMS, a repeat induction RTMS, so a new cycle of RTMS, is effective in bringing upon maintenance similarly as the first cycle. So we have drugs, we have electroconvulsive therapy, we have RTMS, and I haven't spoken about it, but everyone knows we have psychotherapies, right? All of these are valid options for treatment of depression. Irrespective of that, there are still patients that will not respond to any of these alternatives, or patients that, having responded, will relapse very early and not tolerate further treatment. For those, for that very specific group of individuals, this is a very small group of individuals, there are still other more invasive options that are being studied. They're not in current use, I believe, at least not in Europe, not in the United States, but they were to some degree in current use in the past. partly as a responsibility of the work of Egas Muniz in Lisbon in the early 20th century. Sorry, mid-20th century. So this is a review of stereotactic neurosurgical procedures used in psychosurgery in the United Kingdom in the 50s to the 70s. And this is, to some degree, my opinion. Psychosurgery was one of the first interventions, one of the first clinical interventions that to some degree started to think about mental disorders as disorders of neuronal circuits and trying to intervene in these circuits to change the manifestations of disease. And currently, as I said, ablative psychosurgical interventions are not done at all or are very rare, but we're starting to have deep brain stimulation, which is non-ablative neurosurgery, being used more and more, particularly in Parkinson's disease. So this is now an accepted treatment for Parkinson's. Essentially, it consists on implanting an electrode into deep areas of the brain and then passing current through that electrode at a specific frequency, at a specific intensity, to obtain amelioration of symptoms. As I said, it is approved of current use in Parkinson's disease. And what became very obvious in the use of deep brain stimulation for Parkinson's is that the effects of stimulating the brain focally are not restricted to the motor system, as I believe would be obvious to anyone who thinks a little bit about systems neuroscience and about behavior. So this is a case report that was published in 1999 in the New England Journal of Medicine. And it's a case report of a lady who received bilateral deep brain stimulation in the subthalamic nucleus for treatment of Parkinson's disease. And the electrode, as it's not very obvious here, but as you see, it has several contacts to allow the physicians and the neurosurgeons to then identify what's the best contact to obtain the best clinical response. And this is, as is typical in neurology and psychiatry, somewhat of a trial and error process. You try one electrode contact, you try another until you find the one that's best. And in this specific case, there was one electrode contact that, when activated, had an immediate and catastrophic emotional response that was reproducible and reversible upon interruption of the stimulation. So what we see here is in image A, this lady is not being stimulated, and in B, they started to stimulate a particular electrode contact in the interface between the subthalamic nucleus and the substantia nigra. And it's just approximately 4 to 5 minutes later, she starts to complain that she's feeling deeply sad, that she feels that her life makes no sense, and starts to describe some elements of suicidal ideation. She's crying, her facial expression is clearly very much modified. And this obviously is something that induces turning off the electrode contact. And image D is the same person 5 minutes after turning off the electrode with a total dissolution of all of these emotional symptoms that she had described earlier. So this is part of the evidence that focal stimulation of the brain can induce effects, clinical or side effects, that are non-motor. And another very interesting case report was published in The Lancet in 2002 by a French group. And what these researchers were able to demonstrate was that in a patient with Parkinson's disease and that also had obsessive compulsive disorder, so the patient had two disorders, and he was proposed for deep brain stimulation to treat Parkinson's. And they were very surprised to see that after being stimulated for Parkinson's with good effects for several months, the obsessive-compulsive disorder that had been resistant to other options of treatment also started to improve. This was published, was a base for a phase 1 clinical trial for subthalamic nucleus stimulation in obsessive-compulsive disorder that is successful. And currently, there is a randomized controlled trial that is under development, mostly in France, to test the controlled effect of STN, deep brain stimulation, in the context of obsessive-compulsive disorder. But I've been talking to you mostly about depression, and there are also some options for DBS in depression. Unfortunately, the story is slightly less enthusiastic, but I wanted to tell it to you anyway. So the interesting thing about deep brain stimulation for depression is that it was developed essentially on a knowledge base. It was not serendipitous. It was developed because there was a specific target that seemed to be a good target to treat depression in these individuals. And this is the evidence that was used by the researchers to sustain experiments trying to do deep brain stimulation in a particular area of the cingulate cortex, the subgenual cingulate cortex, to treat depression patients that had not responded to any prior treatment alternative, including electroconvulsive therapy. And so the evidence was that when individuals are asked to think about a sad autobiographical memory, this area of the cingulate cortex has increased activity. This is F over there. That red area is the subgenual cingulate cortex in panel F, and it's increased when healthy individuals think about sad events. Also, in individuals that had recovered from depression, and we know that in these individuals, if we do an experiment of tryptophan depletion that reduces serotonin in the central nervous system, there is a momentary relapse of depressive symptoms. In these individuals, when we do tryptophan depletion and they become, let's say, I wouldn't want to say depressed, but sad, the subgenual cingulate cortex also lights up. It's also more active. Also in individuals with genotypic differences in the SERT gene that also is a promoter of the development of depression, there are differences in activity in this area. And finally, in post-mortem studies of chronically depressed individuals, there are histological differences in this area when their comparisons are done with control individuals. Furthermore, in individuals that are depressed and that improve from depression, be it in A, due to a drug, in B, due to a placebo intervention, in C, due to repetitive TMS, or in D, due to electroconvulsive therapy, that increased activity is consistently decreased among different studies. So the rationale then became, if this area is increased in individuals that are depressed or sad, and if we are able to reduce that activity in individuals that are effectively treated for depression, why not target that area specifically to treat depression in individuals where we are not obtaining any kind of effects from other interventions? So this is not serendipity, right? This is systems neuroscience at the service of development of novel treatments. And Helen Mayberg, a neurologist who has worked in Canada and in the United States, published in 2005 the first trial for subgenual cingulate deep brain stimulation in 6 ultra-resistant depressed individuals. So individuals that have gone through every kind of treatment. And that was actually part of the requirements for ethical approval of the study, that there was no other alternative available for these individuals. And in 6 ultra-resistant patients that we know from evidence have a very low likelihood of spontaneous recovery, 4 of them recovered very significantly when they were stimulated in the subgenual cingulate cortex. And in 2002, there was a follow-up study. The first author was Holzheimer, It was also in the Mayberg group. And they showed in a larger group of individuals, I believe close to 20, both with unipolar and bipolar ultra-refractory depression, that after active stimulation of the subgenual cingulate cortex, there was significant improvement both in physician-reported depression severity and patient-reported depression severity, and also an increase in functionality as reported through the Global Assessment of Function. There was no significant difference between unipolar and bipolar depressed individuals, and this did in fact seem very, very promising. So there was a company, St. Jude Medical, that picked up on these results and said, well, let's do a randomized controlled trial, which is how we do things in medicine, right? We don't just believe things because people get better. We want to show that they get better relative to a controlled intervention. So St. Jude did this. They started a multi-center trial, I think mostly in the United States, but I believe also with centers in other areas of North America. And in 2012, I believe, they interrupted the trial. Didn't really explain why. And there's some talk about why this could have happened. The only thing that is really consistent is from a review published in 2014, where the authors argue that they have received a letter from St. Jude suggesting that they decided to discontinue the study because in a preliminary analysis, it failed the futility analysis. So what does this mean? This means that it's not that it wasn't working, it seemed like it was working similarly among individuals that had received an electrode and were being stimulated, and individuals that had received an electrode but were not being stimulated, the sham condition for this trial. So individuals that had not responded to anything in the past were responding to something that we believe is an entirely sham effect of being operated on and receiving an electrode bilaterally in the subgenual cortex. And this is not exclusive. This is obviously not exclusive of deep brain stimulation. It's a pity, right? Because we don't have other alternatives for these patients. That's very clear. So if we don't do the trials, we will not be able to offer them this option, and we have no other options. But this is not exclusive to deep brain stimulation. It's just harder to do and much more expensive to do randomized controlled trials using neurosurgical approaches. But the same is true of RTMS. So there have been papers published, this is an example, comparing active versus sham RTMS and arguing that the difference between sham and active is very small. So there really is no reason to use the active if it's not that much different from the sham. So this is the argument from these authors. And ultimately, this is true of our drugs, right? When we do randomized controlled trials across psychiatry, this is not specific for depression, but it's very much clear in depression. This is an example of a recent randomized controlled trial for the last antidepressant that was introduced in the market. The difference in improvement when we compare placebo to the 2 doses of the active drug is not that large, right? It's significantly different statistically, but what many argue is that it's not significant clinically. And we know a lot about placebo effects because we've been doing placebo-controlled trials across different areas of medicine for several decades. And we know in depression that the size of the placebo effect is the main element that is going to determine if the trial is positive or if the trial is negative. The actual size of the therapeutic effect of our drugs in randomized controlled trials is very much similar across trials. And one example of something that has been argued is the reason why we're having less and less drugs being approved for psychiatry is that there is a consistent effect, at least until the year 2000, of an increase in placebo effects with time. So patients are more sensitive to placebo in the year 2000 than in the year 1980, possibly because expectations about the effectiveness of treatment are different in the year 2000 than in the year 1980. That's just my opinion. It could not be true. And the elements that are modulating the size of the placebo effect have been consistently studied because there's so much data. So the number of study centers is an element that modulates placebo. Multi-center trials have more placebo than single-center trials. The dose schedule of the active drug modulates placebo. Flexible dose has more placebo than fixed dose. Longer trials have more placebo than short trials. And studies with more patients have a higher placebo effect than studies with less patients. I'm going to assume this is not the church trying to shut me up. And there was a psychologist in Harvard that did a very influential work in 2008, very similar to the one I presented previously, but comparing in a meta-analysis the effects of placebo with the effects of active drugs and plotting it against the severity of the disease. What we see here in red is the improvement under the active drug across a scale of severity, from low severity to high severity. It's very similar, as you see. That red line, it's almost a straight line, right? And in gray, you see the size of the placebo effect in the same trials across levels of initial severity. And placebo reduces, right? So for more severely ill patients, the size of the placebo effect is lower. And that's what explains why we have more positive trials in severely ill patients, right? It's not that antidepressants work less well in less severely ill individuals. It's just that placebo works better, right? Which is a little bit different from the way we think about this in more current clinical psychiatry, which is that antidepressants don't work in mild depression. They do work. It's just that we are unable to demonstrate a difference relative to placebo. Irving Kirsch was very effective in using this data. And you had this kind of headline coming out in reputable media outlets in the United States. Antidepressants don't work, right? Physical treatments are useless. And if you delve a little bit deeper in the internet and in things that are maybe a little bit less reputable, the message is psychiatry is useless, right? And psychotherapy is the only option. I find it curious that Irving Kirsch is a psychologist, so I would call him a little bit biased. But in any case, he wrote this book as a consequence of this meta-analysis, which he titled The Emperor's New Drugs. The subtitle was Exploding the Antidepressant Myth. This is a quote from Irving Kirsch. And what he said is, to someone who is not currently on antidepressants, I would suggest trying other treatments first. For example, psychotherapy. And what I want to argue with you in the last few minutes of my presentation is that I think Irving Kirsch is wrong, and I'll explain why. So, the reason why we have such a hard time, as I demonstrated earlier, having positive trials, it's because of high placebo effect, not because of less efficacy of the treatments that we're testing. This is true for ECT, it's true for RTMS, it's true for antidepressants. It's less true for psychotherapy because it's much harder to do an adequately controlled trial. What is placebo for psychotherapy? For many, many studies, it's waitlist control. And does any of us believe that the patient that is waiting to start psychotherapy has any expectation about improvement? Obviously they don't, right? They're waiting for treatment. So adequate controls for psychotherapy are very hard to do, but they're not impossible to do. The only thing that's really impossible to do in psychotherapy is to have a double-blind trial, right? The therapist always knows if he's delivering the real therapy or the controlled treatment. Kuipers et al. In 2009 was sufficiently tenacious to go through the hundreds of literature papers comparing different psychotherapies with control interventions and picking out the papers that had the best quality of evidence. Among elements of quality, Kuipers defined that the existence of an adequate control group that could be a control therapeutic, non-pharmacological therapeutic intervention. It could be a placebo drug, right? Not a real drug. He didn't consider that adequate control because that's an active intervention, right? And care as usual was also used as a control element. And I think Irving Kirsch definitely needs to see this and needs to retract some of his comments. Because when we look, so this is a meta-analysis, I've shown you several, the black figure at the lower line, that's the average of the effect. And the average effect of active psychotherapy versus adequate controls is as tiny as the average effect of active antidepressants versus placebo, okay? So it's not that psychotherapy is better. It seems that psychotherapy has the same kinds of problems that were brought up for pharma. In fact, another criticism for psychiatric drugs is that they all have the same efficacy, right? They're all the same. You can have an SSRI, an inhibitor of serotonin reuptake, and we have a specific drug, tianeptine, that's an enhancer of serotonin reuptake. And both of these are antidepressants, even though they seem to have opposing pharmacological effects. And this is another argument to say, well, these drugs don't really do anything, right? They are expensive placebos. But if we compare different kinds of psychotherapies head-to-head, as has been done so effectively in the United Kingdom, comparing head-to-head cognitive behavioral therapy, person-centered therapy, psychodynamic therapies, head-to-head for the same indications, we see that before and after treatment, the amount of improvement across these groups is equivalent. And these are studies with thousands and thousands of patients in each of the different experimental arms. And importantly, when we look at why psychotherapy works, why different psychotherapies work, the majority of the clinical effect results from global factors that are common among the different approaches of psychotherapy, like empathy, like alliance between the user and the provider, and depend much, much less on the specific factors of that specific psychotherapy. And so, psychotherapy isn't that much different from antidepressants. And I was very excited to see that someone has actually compared this head-to-head in a meta-analysis of randomized trials where individuals are randomized to receive either drugs or psychotherapy, right? A well-controlled randomized trial. And there are dozens of these studies with thousands of patients. And just blowing this up so you can see the conclusion, there is no evidence of superiority of psychotherapy versus pharmacotherapy. There's no evidence of superiority of pharmacotherapy over psychotherapy. They seem to be equally equivalent in the improvement of depression and anxiety. So why are we fighting against placebo, right? Why are we omitting treatments that could help individual patients? Because on average, they're not sufficiently different from a control intervention. Essentially, we are not allowing our patients to have what could be a very sophisticated placebo, but it's the only placebo that they have. We don't have alternate placebos for them. And active SSRIs and placebos activate the same areas of the brain. So elements that predict, a neurobiological response to a placebo drug that, as one would expect, predicts the size of the effect to a placebo intervention, also predicts the size of the effect to a real antidepressant. I honestly believe that the way we are collecting evidence and the way that we are approving treatments is not to the best interest of at least a subgroup of our patients. And the evidence actually is much clearer in that we need to work together rather than argue that this is better than that. So the paper I'm bringing here is a paper of maintenance treatment after ECT. So electroconvulsive therapy depressed patients are the worst depressed patients you can have. They've not responded to anything. They have not responded to psychotherapy. They have not responded to antidepressant drugs. You give them ECT, a subgroup of them remit. What to do after you stop ECT? Typically, what people do is either continue ECT or have another trial of an antidepressant drug. This trial was very interestingly demonstrating that the most effective intervention to reduce relapse after electroconvulsive therapy was cognitive behavioral therapy. Right? We need to work together. And actually, going back to Kuipers, in another meta-analysis, the evidence that we have very consistently across the literature is that combined treatment with psychotherapy and with antidepressants is consistently more effective than antidepressants alone and more effective than psychotherapy alone. I'd like to leave you with that message. I hope I've stimulated some discussion. I wanted to thank some of the people I've worked with some of the work I presented for myself, some of the people I've discussed this work with. My email is there if you have any questions. I believe we have a couple of minutes for maybe one pressing question, and I'll be back at the end of the day for a global question and answer session with the other speaker for the day. Thank you.